Good evening to all the doctors. Welcome to the second day of this ECG session. So over to Dr. Sudha ma'am. She is going to continue this session. Thank you.
Good evening. In the last session, I explained you people about the basics of ECG, how to interpret a normal ECG, and how the normal morphology of the ECG looks. Today, I'll be explaining you about the abnormal ECG morphology, how to identify the abnormal morphology, how to obtain the provisional diagnosis of the underlying cardiac problems. Read it, please. So, ಇದು ಪಾಯಿಂಟರ್ ಮಾಡಿ. So, this is the normal ECG morphology. Today, we'll discuss about the abnormal ECG morphology. Okay? So, what your heart signals to tell you? Let us recollect the normal ECG morphology. This is the normal ECG having its waveforms, intervals. This is the wave. P wave, T wave, U wave, QRS complex, PR interval, PR segment, QRS complex, QRS interval, ST interval, QT interval, and U wave. As I already told you, we have to interpret an ECG always in an orderly manner. Like first, after confirming the normal standardization, you have to start interpreting an ECG in the following order. First you have to As I told you, we have to interpret an ECG in an orderly manner. First, heart rate of the ECG, rhythm, axis, P wave, PR interval, QRS complex, ST segment, T wave, U wave, and the UT interval. This is the normal conduction system of the heart. Cardiac impulses are generated by the natural pacemaker of the heart, that is sinoatrial node. From the sinoatrial node, it goes to AV node, then to bundle of his, to the bundle branches, right bundle branch, SA node, AV node, bundle of his, right bundle, left bundle, and Purkinje fibers. Now let us start with the heart rate and the rhythm together. This is the normal regular sinus rhythm. Here the impulses are generated by the SA node and conducted normally. So in the normal sinus rhythm, the parameters are heart rate will be around 60 to 100 beats per minute. Regularity is always it will be regular. P waves are normal in shape and duration. PR interval is from 0.12 to 0.20 seconds. QRS duration is 0.04 to 0.12 seconds. Any deviation from the above is known as sinus tachycardia, sinus bradycardia, or an arrhythmias. So what do you mean by arrhythmias? An arrhythmia is the abnormal heart rhythm at the heart rate. Here the heart may be beating too slow or too fast or with an irregular rhythm. The arrhythmias can rise from the problems in the sinoatrial node, that is the SA node, sinus node, or from the atrial cells, or from the AV junction, or from the ventricular cells. So let us discuss now about the SA nodal problems. The SA node can fire the cardiac impulses too slow, causing sinus bradycardia, or too fast, causing sinus tachycardia. You have to remember here one thing: sinus tachycardia may occur as a response to the stress or during the exercise.
Today.
Sinus bradycardia. Here the sinoatrial node is depolarizing slower than the normal. So the impulse is conducting slowly but in the normal conduction pathway. So this is the ECG showing a sinus bradycardia. Here the heart rate is 30 beats per minute. Rhythm is regular rhythm. P waves are normal in shape and duration. PR interval is around 0.12 seconds. QRS duration is 0.10 second. So what do you mean by sinus bradycardia, sinus tachycardia? In the sinus tachycardia, the SA node is depolarizing faster than the normal but the impulse is conducted normally after the SA node. Remember here what I have told you, sinus tachycardia is the response to the physical or psychological stress, and in that situations it will not be a primary arrhythmia. This is the graph, ECG graph showing the sinus tachycardia with a rate of around 130 beats per minute. Rhythm is regular. P waves are rhythm is regular. RR interval is normal. P waves are normal. PR interval, this is the PR interval is 0.16 second. QRS duration from the Q to the S is 0.08 seconds. So it is sinus tachycardia. So what happens when the atrial cells stimulate or produce the cardiac impulses? When the atrial cells fire occasionally from a focus, it is known as preatrial contractions or PSS. When it fires continuously due to a looping re-entrant circuit, it produces atrial flutter. When the atrial cells fire the cardiac impulses continuously from the multiple foci or due to the multiple micro re-entrant wavelets, it produces atrial fibrillation. Other night. What is atrial fibrillation? Here, the atrial cells fire continuously from the multiple foci. So, there is no organized atrial depolarization. So, there is no normal P waves. Impulses are not only generating from the SA node, they are generating from the other foci also. So the atrial activity is chaotic, resulting in an irregular rate. You can see here this PR interval, and between the two QRS complex, this RR interval is different from this RR interval. So this is irregular. See, this RR interval is different. Each RR interval is different. So it is rhythm is irregular. You can see here the multiple foci other than the SA node in the atrial cells generating the cardiac impulses causing atrial fibrillation. So, in this ECG, the rate is approximately 100 beats per minute. Is it regular? No, it is irregular. Look for the RR interval between this and this. From here to here is the RR interval. This is different from this. So, the rhythm is irregular. Are there any P waves? No, there are no P waves. One or two places you can see the P wave. But here, there are no P waves. Can you record the PR interval? No, because there is no P wave. So, you can't measure the PR interval. What about the QRS duration? QRS duration is around 0.06 seconds. So, this is the ECG showing atrial fibrillation. Remember here that in atrial fibrillation, there is no P waves and the rhythm is irregular. and you can't measure the PR interval. Coming to the atrial flutter, here there are no P waves similar to atrial fibrillation, but instead of small irregular, there are flutter waves. Note this is the sawtooth appearance or form at a rate of 250 to 350 beats per minute. So, only some of the impulses are conducting through the AV node. See, because you are finding a QRS complex in between. So, that means some impulses are conducting from the SA node to the AV node. So, usually every other impulses, like see here the sawtooth appearance you can see, these are the flutter waves. In between, this is the normal QRS complex, PQRS complex. As I told you, here you can see multiple re-entrant. See, this is the re-entrant. From here, it is entering here. From here, again, it is entering back. This is the section of the heart showing you the multiple re-entrant wavelets. So, can you read this ECG? Okay, how to read this ECG? Here, the rate is around 70 beats. Regularity is there? Yes. Most of the times, it is regular because you are getting the PR-RR interval almost regularly it is coming. So, the rhythm is regular. Coming to the P waves looks like flutter waves. See, this is the sawtooth appearance known as the flutter waves. PR interval? No, you can't measure the PR interval. QRS duration? It is around 0.06 seconds. So, what is your interpretation? Interpretation is atrial flutter. So, the difference between atrial fibrillation and atrial flutter is, this is how you can see the in atrial flutter sawtooth appearance, that is the flutter waves. Whereas in atrial fibrillation, you will find fibrillating atria. This is the atrial flutter I have told you. Now let us know about the premature atrial contractions. What do you mean by premature atrial contractions? These are the ectopic beats originating in the atria other than the SA node. Therefore, the contour of the P wave, this is the P wave, and the PR interval and the timing are different from a normally generated pulse from the SA node. This is the normally generated cardiac impulse from the SA node, whereas this is the PQRS complex originating from the atria other than SA node. Here you can see this is the normal SA node to the AV node. Bundle of is the conduction pathway. Here it is cardiac impulse are transmitting both right atria and the left atria. But in premature atrial contractions, there is an ectopic site you can see here. From here, other than the SA node, this ectopic site is also generating the cardiac impulses. This produces this premature contraction of the atria. Here also you can see this is the foci, ectopic foci producing an premature atrial contraction identified like this on the ECG. So this is the ECG strip showing the premature atrial contractions. What is the rate? Approximately it is 70 beats per minute. Is it regular? Is the rhythm regular? Occasionally irregular, because see here the RR interval is same. So it is regular, but from here to here, whenever you get a premature atrial contraction, the RR interval is becoming different. So it is occasionally irregular. What about the P waves? Whenever there is the impulses from the SA node, your PQRS complex is normal with the normal P wave. But whenever it is originating from the ectopic foci, it is not normal. So PR interval also, it is sometimes in the normal side, you can measure it is approximately about 0.14 seconds. And QRS duration is almost same, that is 0.8 seconds. This is with this parameters, the interpretation is normal sinus rhythm with premature atrial contractions, because here the rhythm is regular. Now let us know about the paroxysmal supraventricular tachycardia. This is also an arrhythmia deviated from the normal sinus rhythm. Here, the heart rate suddenly speeds up, often triggered by a premature atrial contraction. Here, I am not showing the premature atrial contraction, and the P waves are lost. See, here, this is the regular normal sinus rhythm. After certain period, it starts speeding up. Here there is no P wave triggered by usually it is triggered by the premature atrial contraction. What is the etiology of paroxysmal supraventricular tachycardia? There are several types of paroxysmal supraventricular tachycardia, but all of them originate above the ventricles. Therefore, the QRS complex is narrow. What are the types of paroxysmal supraventricular tachycardia? This is the atrioventricular nodal reentrant tachycardia. Here, the AV nodal, the electrical impulses re-entry around the AV node due to the AV nodal pathway. Having AV nodal, other than the AV node, there is another pathway. Hence, the AV node has dual pathways. Here, one pathway will go like this, the other pathway also will go like this. So, here you can see the two pathways. So, this is the normal rhythm in supraventricular tachycardia. As I told you, the heart rate will speed up after a certain period of time. This is the other type. It is the atrioventricular reentrant tachycardia. Here, the electrical impulses re-entry via the accessory pathway. Initially, atrioventricular atrioventricular nodal reentrant pathway, that is here, there is a dual AV nodal pathways are there. Whereas in this, there is an accessory pathway present above the bundle of his, that is above the ventricular activity. This is the focal atrial tachycardia. This is the other type. Usually the main three types I am mentioning you people. In this focal atrial tachycardia, there is abnormal origin of electrical impulses in the atria producing tachycardia. So, what is the rate? Rate is between 74 initially. It has increased to 148 beats per minute. Regular? Yes. Initially also it was regular. Again also it is regular. P waves? Normal to none. RR interval, PR interval? 0.16 second to none. QRS duration 0.08 seconds. So, your interpretation is paroxysmal supraventricular tachycardia. Coming to the ventricular arrhythmias, here the ventricular cells fire occasionally from one or more foci. When it fire from one or more foci, it produces premature ventricular contractions. These ventricular cells can generate the cardiac impulses from one or two foci, but it can also generate from the multiple foci. When it is fires the continuously, that is the ventricular cells fire continuously from the multiple foci, then it produces ventricular fibrillation. When it fires continuously due to a looping reentrant circuit, it produces ventricular tachycardia. I'll be showing the pictures in the next slides when I going to explain you in detail about the each type, that is premature ventricular contractions, ventricular fibrillation and ventricular tachycardia. So coming to ventricular tachycardia, there is a reentrant pathway looping in the ventricle. See, this is the right ventricle and left ventricle. There is a reentrant looping pathway in the ventricle producing continuous discharge of electrical or cardiac impulses. This ventricular tachycardia sometimes can generate some enough cardiac output to produce a pulse. But most of the times in patients presenting with the ventricular tachycardia, you cannot feel the pulse because of multiple contractions of the ventricles are not able to pump the blood sufficiently. This is the slide showing you the, as I told you, looping reentrant wavelets. So, how it is deviated from the normal sinus rhythm? Here, there are no P waves, only the wide QRS complexes. So, the ventricles so the impulses are originating only from the ventricles. So, what is the rate? Rate is around 160 beats per minute. Is it regular? Yes, it is regular. P waves, there are no P waves. PR interval, you cannot measure PR interval. QRS duration, it is quite wide, more than 0.12 seconds. Then your interpretation is ventricular tachycardia. Let us know something about the ventricular fibrillation. Here also the ventricular cells, multiple ventricular cells gets excited and start generating the cardiac impulses. That is, the etiology is the ventricular cells are excitable and produces the cardiac impulses causing the depolarization randomly. There is a rapid drop in the cardiac output in the ventricular fibrillation. This ventricular fibrillation is a most serious and one of the serious and a life-threatening arrhythmia where the lower heart chambers, that is the right and the left ventricles, contract in a very rapid and uncoordinated manner, resulting in the condition causing the heart now unable to pump the blood to the rest of the body. It is an extremely dangerous situation, can lead to sudden death. These are the, you can see the multiple relooping circuits. This is the chaotic heart rate. Ventricles just triple rather than beat. Here you can see the normal sinus rhythm, SA node, AV node, everything. But here SA node to AV node, here multiple foci of impulses causing the ventricles to tremble or shaking rather than to beat. This normal sinus, is it normal sinus rhythm? No, it is completely abnormal. See, rate, you can't measure the rate because there is no regular rhythm. So P waves, can you see? No, you cannot see the P waves. Can you measure the PR interval? No, you cannot measure. QRS duration is irregular. Sometimes it is very wide and sometimes you cannot measure also. So interpretation is atrial fibrillation. Now let us know about the premature ventricular contractions. In premature ventricular contractions, one or more ventricular cells are depolarizing and the impulses are abnormally conducting through the ventricles, causing a ectopic beats. This ectopic beats originate in the ventricles, resulting in the wide, this is the wide bizarre QRS complexes. When there are more than one premature beats and they look alike, they are called uniform. When they look different, they are called multiform. Here I will show you one more. Here it is looking different, whereas in this, here it's only one premature ventricular contraction is there. This is uniform, whereas this is multiform. This multiple foci producing multiple forms of premature ventricular contractions. Here the impulses, as I told you, impulses originates in the ventricle and conducting through the ventricles will be inefficient and the QRS and hence the QRS complexes will become wide and bizarre. This is the normal cardiac axis. As we all know that the cardiac axis represents this is the cardiac axis, normal range. This is the cardiac axis. This represents the direction of the heart's electrical activity, specifically the net direction of the ventricular depolarization. You have to check the QRS complexes in the lead 1, lead 2, lead 3 and AVF. In the normal electrical axis, QRS is positive in lead 1, lead 2, lead 3 and lead AVF. Yesterday I have told you about how you have to calculate or interpret the cardiac axis by the quadrant method. According to this quadrant method, you have to measure the R wave. You have to measure the R wave and S wave. If the R wave is larger than the S wave, it is positive. If the R wave is smaller than the, here it's not there. If the R wave is smaller than the S wave, it is negative. So, in the normal axis, in the lead 1 and lead 2, it is positive. In the left axis deviation, lead 1, it is positive. That means R wave is larger than S wave, whereas in lead AVF, R wave is smaller than S wave. Hence, it is possibility of left atrial deviation. Coming to the right atrial deviation, here the R wave is smaller than the S wave in lead 1, whereas in the lead AVF, R wave is larger than the S wave in the right axial deviation. See, I am showing here. This is the right axis deviation. This is the right axis deviation. The QRS complex, negative QRS in the lead 1 and positive in lead 2. See, you can see the R wave is very small. You can't measure. The S wave is there. So, it is negative. Whereas the R wave is larger than the S wave. Hence, it is positive in lead 2 and positive in lead 3. R wave is larger than the S wave, and even in the AVF, R wave is larger than the S wave. So, in the right axis deviation, the QRS is negative. That is, R wave is smaller than the S wave in lead 1 and positive in lead 3 and what are the causes for the right axis deviation? Most commonly, it is seen in right ventricular hypertrophy, right bundle branch block, and left posterior hemiblock. I have already explained you how in the right axis deviation, it is QRS is negative in the lead 1, positive in lead 2, lead 3, and AVF. Coming to the left axis deviation, the QRS is positive in lead 1 but negative in lead 2, lead 3 and AVF. Here you can see the lead 1 R wave is larger than the S wave, so it is positive, whereas in the lead 2 and lead 3 R wave is smaller than the S wave, so it is negative. Even in the AVF also R wave is smaller than the S wave, so it is negative. Causes are left bundle branch block, left ventricular hypertrophy, and the left anterior hemiblock. So, coming to the right ventricular hypertrophy, what are the features of right ventricular hypertrophy? In the right ventricular hypertrophy, as I already informed you that there will be right axis deviation. There is dominant R wave in the V1 and dominant S wave in V5 or V6. Here you can see dominant R wave in V1, V2, V3, V4. Whereas dominant S wave in V5 and V6 compared to R waves. Dominant it is. Usually in the right ventricular hypertrophy, it is associated with the right atrial enlargement. I will be explaining you about the P pulmonale in the next slides. It will have this P pulmonale and there will be a right ventricular strain pattern, that is ST depression or T wave inversion in the right precordial leads, that is V1 to V4, V1, V2, V3, V4, and inferior leads such as lead 2, lead 3, and AVF. You can see here lead 2, lead 3, and AVF. This is flow pattern is there. Coming to the left ventricular hypertrophy, there will be left axis deviation and increased R wave amplitude in the left-sided ECGs, that is lead 1, AVL, and V4 to V6, and increased S wave depth in the right-sided leads, lead 3, AVR, and V1 to V3. Here you can see the increased R wave pattern in AVL. R wave is large, and lead 1 it is large, and V5 and V6 it is large. R wave amplitude, I am telling you about the amplitude of R wave. Lead V5, V6, lead 1, and in AVL. And what about the S wave depth? S wave depth in the right-sided leads are increased. Here is the lead 3, it is increased here, and AVR, it is increased, and V1 to V3. You can see the amplitude of S waves. It is greater than the R waves. And left ventricular strain pattern you can see, that is ST depression in the lead 1. You can see the ST depression. This is the ST segment. You can make out this ST segment depression in the lead 1, lead AVL. You can see the depression here, and V5 and V6. Here also you can see the ST depression. Whereas in the lead V4 you can see the normal. You can make out the difference from the V4 to V4 and V5. In here it is isoelectric, but here it is T wave depression is there. Coming to the P wave. This is the normal P wave with the width of less than 3 small squares and the amplitude of less than 2.5 small squares. It is always positive, as I have informed you yesterday about the P waves. It is always positive in lead V1, lead 1, lead 2, lead 2, and it is always negative in AVR, and it is commonly biphasic in lead V1. This is the P wave. This first 1/3 of the P wave represents the right atrial activation. The final 1/3 represents the left atrial activation, and the middle is the combination of two. This is the normal P wave. Let us see how the abnormal P wave looks. This is the P pulmonale. In the P pulmonale, the right atrial depolarization, this is the brown color is the right atrium. Right atrial depolarization lasts longer than the normal. Usually it should be 1/3, but it is lasts longer. Lasts longer, almost it is extending up to the end of the left atrial depolarization. Blue is the left atrium, brown is the right atrium. So you can see the depolarization of the right atria extending up to the end of the left atrial depolarization. Here the amplitude of the P wave also is increased. Coming to the P mitrale. This is the P mitrale. How it looks. Here the left atrial depolarization lasts longer than the normal, but its amplitude remains unchanged. Whereas in this, the P wave amplitude is increased in P pulmonale, whereas in P mitrale, that is left atrial enlargement, the amplitude remains unchanged, but the left atrial depolarization lasts longer than the normal, producing this biphasic type. It's not biphasic, mitrale. You can see here with the waveform. This is the P pulmonale. You can see the increased tall peaked P waves. Generally, it is due to the enlargement of the right atrium. I have already told you in the previous slide. This is the right atrial depolarization lasts longer. Hence, it is enlarged right atrium. It is commonly associated with the congenital heart diseases, tricuspid valve disease, and also the pulmonary hypertension, and in cases of diffuse lung diseases, you can see this form of P wave, that is P pulmonale. Coming to the P mitrale, here the left atrial depolarization lasts longer than the normal, producing a wide P wave, often bifid. This is the bifid, whereas this is biphasic. Bifid. It may be, most of the times, it is due to the mitral stenosis or left atrial enlargement. Coming to the biphasic P wave, it is biphasic. This is positive and negative. Its terminal, this P wave in its terminal part shows the negative deflection of more than 40 milliseconds wide and more than, this is the depth. This is the amplitude, that is more than 1 millimeter deep in an ECG. It is a sign of left atrial enlargement. So, in left atrial enlargement condition, you can see biphasic P waves or P mitrale. This is the normal QRS complex. This Q wave, amplitude of the Q wave should be less than 1/3 of the QRS amplitude or wave, R and S. This is the amplitude of R and S. This Q wave amplitude should be less than 1/3 of the R and S amplitude. And this S amplitude in the V1 and R amplitude, this is the R amplitude from here to here, and from here to here it is the S amplitude. So S amplitude in V1 and R amplitude in V5 should be less than 3.5. So, and coming to the duration, it should be less than 3 small squares, that is 0.06 to 0.1 second. What happens when the QRS complex is abnormal? In the QRS, as we all know that QRS complex represents the depolarization of both the ventricles, that is right ventricle and the left ventricle. So, the depolarization of the bundle branches and the Purkinje fibers are seen as the QRS complex in the ECG. Therefore, whenever there is conduction block of the bundle branches, there will be change in the QRS complexes. So, whenever there is changes in the bundle branch transmission resulting in the bundle branch blocks, you will see two changes in the ECG, especially in the QRS complex. The QRS complex widens, the duration becomes more than 0.12 second, and the QRS morphology changes, depending upon the ECG lead. If it is a right versus left bundle branch block. Let us see how why the QRS complex widens. When the conduction pathway is blocked from the bundle of His or at the right bundle or the left bundle, It takes the conduction pathway of the right ventricle or the left ventricle takes longer time for the electrical signals. These are the electric. If it is blocked, it takes longer time for the electrical signals to pass through the ventricle. If it is right bundle branch block, there will be longer time for the electrical signals to pass through the right ventricle. If it is left bundle branch, it takes longer time for the signals to pass through the left ventricle. So, in left bundle branch block, there is indirect activation causing the left ventricle to contract later than the right ventricle because of the left bundle branch block. What you will see in the left bundle branch block? The QRS complex in the V1 is W-shaped. Here you can see QRS or RS. R wave is small and S wave is large. There is a mnemonic to remember the left bundle branch block and the right bundle branch block. For left bundle branch block, it is William. Whereas for the right bundle branch block, it is Marrow. V means in the V1, it is W-shaped. Whereas in the V6, it is M-shaped. Coming to the right bundle branch block, the terminal R waves in the V1 is M-shaped. This is the opposite. Here you can make out this M-shape. Whereas in the V6, it is approximately W-shaped. You can remember by the mnemonic as Marrow. V1, it is M-shaped. V6, it is W-shaped. Whereas in left bundle branch block, it is W-shape in V1 and M-shaped in V6. So in both the left bundle branch block and the right bundle branch block, there is wide QRS complex. I am going to explain you again that there will be a broad notched R wave in the lead V1 and V2 in right bundle branch block, whereas that is M pattern, whereas in the lead V5 and V6 lead 1 and AVL in the left bundle branch block, that is okay. It is whereas in the leads V5 and V6 lead 1 and AVL, there will be a broad notched R wave in the left bundle branch block. This left bundle branch block indicates more severe disease. In presence of LBBB, that is left bundle branch block, you will have the problem in diagnosing the left ventricular hypertrophy or MI. Coming to the normal Coming to the normal PR interval, that is starting of the P wave to the starting of the QRS complex, is normal PR interval is 3 to 5 small squares, that is 120 to 200 milliseconds. What are the different types of heart blocks? There are 3 different types of heart blocks. First degree heart block, second degree are the Mobitz type 1. second degree type 2 or Mobitz type 2. And third degree are complete heart block. I have told you this is the normal PR interval. What happens when the PR interval becomes longer? So it indicates the heart block. As I told you, there are three types: first degree, second degree, and third degree. First degree, here the PR interval will be constant, but it is prolonged. But there is no change in the duration of PR interval. It is usually more than 200 milliseconds. Here you can see it properly. This is a first degree heart block. The P wave precedes the QRS complex normally, but the PR interval is larger than small squares. Normal is up to 3 small squares, but here it is more than 5 small squares. But this PR interval is constant. That is, there is no change in the PR interval. Hence, when there is no change in the PR interval, you have to come to a conclusion that it could be a case of first degree heart block. In second degree heart block, as we all know that there are two types, Mobitz type 1 or Wenckebach's and Mobitz type 2. In Mobitz type 1, this PR interval changes its duration or interval of the PR interval goes on changes. First, the PR interval will be normal. With the successive beat, this PR interval lengthens. See, from here to here it has increased. Again, from here to here it has increased until there will be a P wave with no following QRS complex. Here is the P wave, but it is not followed by the QRS complex. Hence, it is known as the P with dropped QRS complex. Again, it will start with the almost normal. Again, the PR interval goes on increasing. This indicates that there is block at the AV node. Usually it is transient and it is asymptomatic. Coming to the second degree heart block type 2, that is Mobitz type 2. Here the PR interval is constant, same as the first degree heart block. But periodically there is no conduction between the atria and ventricle. See, this is the normal conduction. Afterwards, this is a blocked P wave. There is no QRS complex. It's known as blocked P wave. Again, there will be a normal PQRS complex. Normal with a normal PR interval. This block is often below the AV node. Mobitz type 2 is at the AV node, whereas Mobitz type 2 is below the AV node. It could be at the bundle office or bundle branches. That is, it could be right bundle branch or left bundle branch. Most of the times, this Mobitz type 2 progresses to the third degree block. Coming to the third degree block or complete heart block, it is also known as the Stroke-Adams syndrome. This complete heart block calls for an emergency pacemaker insertion. Here you can see there is no relationship between the P waves and the QRS complexes. There is an accessory pathways and accessory pacemaker in the lower chambers, that is the left ventricle and the right ventricle, which causes the depolarization of the ventricles, causing an escape rhythm. Here the atrial, these are the atrial P waves. Atrial rate is around 60 to 100 and the ventricular rate, that is from the RR interval, based on the site of escape pacemaker, the atrial rhythm could be regular or irregular, but most of the times both the atrial and the ventricular rhythm are regular. Here you can see the escaped rhythm. This is the ECG showing complete heart block with the escape rhythm. Here is the P wave without QRS complex, known as the escape rhythm. What do you mean by Wolff-Parkinson-White syndrome? Wolff-Parkinson-White syndrome, commonly known as WPW syndrome, is a congenital pre-excitation syndrome characterized by the specific pattern on the ECG, indicating the presence of pre-excitation of the ventricles due to an accessory pathway, that is known as bundle of Kent. You can see here three colors: red color, red bar, blue bar, and the green bar. This red bar, this is the red bar. This is the short PR interval of 0.08 seconds and the long QRS complex, this is the green, is the QRS complex of at 0.12 seconds and this blue one is the delta wave. This is the delta wave. See here properly, this is the delta wave. This presence of delta wave is better seen in the long strip, that is the rhythm strip of lead 2, which is usually at the lower end of your ECG paper. So this accessory, because of this accessory pathway, the ventricle beats prior to the normal pathway. So this upstroke, this is the slurred upstroke of the QRS complex denotes the delta wave. This presence of delta wave is the hallmark of pre-excitation syndrome. That is due to the presence of accessory pathway allowing the activation of the ventricle prior to the normal activation of the ventricles. That is normal depolarization of the ventricles. You have to, again I am telling you, this is the delta wave pathognomonic feature of WPW syndrome. Today I am ending with the session. Till I have covered you about the heart rate, abnormalities in the heart rate, rhythm, QRS complex, PR interval, and bundle branches blocks and the heart blocks. Tomorrow I will be dealing you with abnormalities of T wave, ST segment, and QT interval. Any questions? I'm going to unmute the session. So
Hello,
yeah, tell me, ma.
ma'am. The question is, ma'am, this PR interval abnormal in every lead, ma'am, like lead 1, lead 2, AVR lead, and
Yes.
then
Yes. This what happens now if the PR interval that is associated with the other conditions then you will find in other leads also. But this most of the times, this PR interval, what I have told you, this is the this PR interval. It occurs in all the leads, but better seen in the long string.
Okay, ma'am. Thank you.
Any other questions? Any questions?
Ma'am,
Yeah, tell me.
that PR interval in all degree of heart block, will it be prolonged only?
No, I have told you, no? See, in the first degree heart block, it is normal. Okay. But it is, in the first degree heart block, it is prolonged, but it will be same. Whereas in the second degree heart block, there will be normal also will be there and prolongation of the PR interval also will be there. Whereas in first degree block, there is prolongation of the PR interval will be there. But at each QRS complex, the PR interval will be not same. There won't be any change in the duration of the PR interval. If the PR interval is prolonged, you see that if the PR interval is prolonged in all the leads, but remaining constant, then it is first degree block. You got it?
Yes, ma'am. Yes, ma'am.
In second degree block, that is in the type 1, normal it can be in the first or any beat, it will be normal. It is followed by the beats which has got prolonged PR interval. This PR interval duration will not be same. It will be go on increasing up to a point where there won't be any P wave without any QRS complex. You got it?
Yes,
Here
ma'am.
the
Yes.
PR interval from normal to it will go on increasing till a missed bit, that is P wave without QRS complex. Again here it is normal. Again it is go on increasing. Then it is known as second degree. Whereas Morbid's type. Whereas in Morbid's type 2, here the PR interval is increased but it is constant. There is till there will be a blocked P wave. That means there is a P wave without a QRS complex. That is, there is a P wave with no associated QRS complex. Here, as I told you, the block will be at the level of AV node. It is at the below the AV node. In Morbid's type 1, it is at the AV node. When the block is at AV node, the PR interval goes on increasing till you get a P wave without the QRS complex. Whereas in Morbid's type 2, the PR interval will be constant. There is no increase. But till you will get a blocked P wave. That is P wave without QRS complex. Here the block is below the AV node.
Okay, ma'am. Thank you.
Okay. Any other questions?
Ma'am, how to measure an heart rate in this heart blocks, and it is always in the bradycardia, or we have how to measure it, ma'am? Because one.
Okay, here you are in this Morbid's type, there is a regular heartbeat will be there. Okay, from RR interval only you have to take the heart rate. Okay, but in not between the blocked P wave. When there is two normal QRS complexes are there, you have to take the RR interval between the two normal complexes. Then you will get the heart rate. Same in the type 1 also. In the type 3, in the first degree also same. In the first degree, it is not same because each time the PR interval goes on increasing. So your RR interval also will increase. So here it is not the regular interval. You have to take, I have told you yesterday, there are two methods for calculating the heart rate. One is 300, rule of 300. The other one is 10-second rule. In the 10-second rule, you have to count the number of beats in 50 large boxes or the big boxes. That should be multiplied by 6. You will get the heart rate. So when there is irregularity, you have to count in the method of 10-second method. 10-second rule or 10-second method. You want to know that thing? I'll show you again. Yesterday I have told you how to calculate the heart rate. There are two methods, rule of 300 or 500, that is for the regular rhythm if the RR interval is small, and the second one is 10-second rule. In rule of 300, count the number of big squares, big boxes, and divide by 6. In 10-second rule, count the number of the beats present in the ECG during 10 seconds or 50 big squares. You have to count the beats in big 50 squares and multiply this by the 6. You will get the heart rate. Got it?
Yes, ma'am. Thank you, ma'am.
You just tell me whether you have understood or not. You come to know how to calculate the heart rate in presence of heart blocks.
Yes, ma'am. I understood, ma'am. Thank you.
Okay. Any more questions? Yeah. Now I'm going to wind up. Tomorrow I'll be dealing with the further abnormal morphology in the ECGs. Actually, day before yesterday, the session was not properly done due to the technical issues. So we are extending our session to tomorrow also. By tomorrow, we are going to complete our 3-day session. Okay, tomorrow we'll meet you people at 7 p.m. Thank you.
Thank you all.